Hello, and welcome to the latest in our axial spondyloarthritis podcast series. We'll be bringing you new episodes on a monthly basis alongside with our RA and PSA podcasts, and we'll also be supplying you with monthly slide decks to help keep you up to date with the latest research and publications in the field of axial SPA. First, allow me to introduce myself. My name is Sofia Ramiro, consultant rheumatologist and senior researcher at Leiden University Medical Center and Zuiderland Medical Center in the Netherlands. Here today with me, we have Professor Hideto Kameda, Professor of Internal Medicine at Toho University. And we are also joined by Professor Xenofon Baraliakos, Professor of Internal Medicine and Rheumatology at the Ruhr University in Bochum, and Medical Director of the Rheumatology Center Rheumatzentrum Ruhrgebiet in Herne, Germany. And of course, if you want to find out more about the papers that we discussed today and about us, please head over to the Immune-mediated Inflammatory Disease Forum website, www.imidforum.com. So Hideto, over to you.
Okay, thank you, Sophia. In the first paper, we will discuss today the authors explored bone-related outcomes and bone turnover markers over 2 years in patients with radiographic axial SPA, receiving Secukinumab in daily clinical practice. Following on from this, we will discuss our second publication where investigators sought to determine suitable clinical scenarios for administering JAK inhibitors in clinical practice, as well as to develop regulatory guidelines on the use of JAK inhibitor therapy in high-risk patients. Now, over to you, Xenofon.
Thank you very much, Hideto. As you mentioned, our first paper is dealing with bone metabolism. It's entitled The Effect of 2 Years of Secukinumab Treatment on Bone Metabolism in Patients with Radiographic Axial Spondyloarthritis, authored by Siderius and colleagues. For the study background, we know that radiographic axial spondyloarthritis is associated with bone formation and bone loss, characterized by changes in bone-related outcomes and bone turnover markers, BTMs in short. TNF blockers and IL-17 blocking therapies have been shown to lower the disease activity in patients with radiographic axial spondyloarthritis, as shown through changes in these BTMs. Treatment with IL-17 inhibitors such as Secukinumab did not previously show significant changes in BTMs over 1 year, and the study monitored bone-related outcomes in BTMs over 2 years in order to study the long-term outcomes of Secukinumab treatment. For the methods, included were consecutive patients with r-AxSpA outpatients from the Groningen Leeuwarden AxSpA cohort, the GLASS cohort, treated with Secukinumab over 2 years. The baseline in 2 years, spinal radiographic damage was assessed using the following 3 measures. The well-known EMSAS score, the Modified Stokes Ankylosing Spondylitis Spinal Score, cervical facet involvement according to the FLAM scoring method, and radiographic vertebral fractures via the Genand method. All of these are well known in the literature. At all visits, BTMs reflecting collagen resorption, collagen formation, and bone mineralizations were measured and expressed as Z-scores to correct for the normal influence of gender and age. For the results, patient characteristics reflected the well-known general AxSpA population with a male representation of 53%. Disease activity scores were representative of the general AxSpA population. The 2-year progression rates for both bone-related outcomes were below the smallest detectable change, and only 1 patient experienced a vertebral fracture. Serum levels of SCTX, it's a serum C telepeptide of type 1 collagen, and PINP, the collagen type 1 N-terminal peptide, showed no significant changes from baseline, whereas BALP, the bone-specific alkaline phosphatase, decreased significantly with a median Z-score of -1.2. So as a conclusion, Overall, the results show spinal radiographic progression, which is low during the 2 years of follow-up and correspondent with previous measure 1 and the SURPASS trials. Bone-related outcomes such as the EMSAS, fast joint score, and collagen resorption, BTMs such as SCTX and PINP, remain constant, whereas BALP levels decrease significantly over 2 years. The BTM data from 8 patients at 3 years of follow-up showed a sustained decrease in the BALP levels. What this means? This means that these results are in line with in vitro studies and highlighting, then they highlight the ability of IL-17 subtypes A and F to promote osteogenic differentiation and matrix mineralization. Now, the question is, of course, what is the lesson to learn for the daily practice? I'm happy to discuss this with you here. These are biomarkers and parameters that we do not use in daily practice, obviously, but still in terms of the literature and the data we have otherwise, we know that they have been, these bone biomarkers have been well explored in other studies. As I mentioned, also showing similar results, but now for IL-17 inhibitors. I would like to know what you think about that.
Thank you very much, Xenofon, for this nice overview of this paper. And indeed, you already started the discussion and question that I also had in terms of which are the lessons to take from this paper. But before we go there, maybe I would go one step even earlier, which is, I think the authors described, of course, structural damage occurring in the study, described the evolution of the bone markers, but they are not really relating them. Maybe there is a reason for that. Also, the evolution of each of them is probably showing us indirectly, although that I don't see the relationship in the paper, it's probably showing to us that there is no relationship. But in the end, what I think we would all like to see, and what a lot of research has been put, is to see if we can find biomarkers that can predict patients that will have or that will not have progression of structural damage. What do you think about this?
Well, maybe I'm biased because I have a predefined opinion here, and I think this predefined opinion reflects what everybody else in the field believes, which is that we cannot trust at the moment the biomarkers at all, neither for prediction nor for monitoring. Independent on whether or not we are doing these biomarkers, we're looking at these biomarkers in daily practice, which we do not do. Obviously, the best biomarker for that is still CRP, which is still only by 50% of patients positive. So I do agree with you fully. This is not being shown here. It would be extremely strange if all of a sudden something would come up. I remember all studies that were showing in large cohorts, such as ASSERT and the others, that there might be one or the other correlation, but this has to do more or less with the fact that whenever you look for something, you may always find a correlation by chance. You need to reproduce it. So these things are not reproduced. I'm rather of the opinion that this study shows that there might be some blood parameters, I call it now, not even biomarkers, that may show a tendency. But certainly that's, I believe, something that is nice to know, but not more than that.
Thank you very much. I think we fully share your preconception about biomarkers as you mentioned it. So I share totally your view. Hideto, what do you think about this?
Okay, so serum biomarker reflects enthesis, focal region, and also some systemic bone turnover. So we do not know what is reflecting the enthesitis regions or some systemic bone turnovers. And my point is this study shows that some decrease in alkaline phosphatase activity. But I believe that one study, and Xenofon may be involved in that, some post hoc analysis of measure 1 study suggested that after secukinumab treatment for 2 years, some increase in bone mineral density was observed. Is that correct?
That is correct. The question is now, are we indirectly increasing bone mineral density because we decrease inflammation? We know that, by the way, that locally there is osteoporosis even around the syndesmophytes if you find inflammation in the syndesmo in the biopsy. So is it rather an indirect effect, or is this really an effect? And increasing bone mineral density doesn't mean that we increase new bone formation, we just improve osteoporosis. Yeah. So yes, this data exists. There's also very old data from Berlin that showed that we have osteoporosis and bone degradation at the same time in this disease. As you mentioned very clearly and correctly, this is an enthesetic, obviously, enthesetic ossification. So, and by the way, I think we all agree here, we are looking into patients with radiographic r-AxSpA. There is already a long time gone until they come to that stage. So we don't even know, as Sofia said, we don't know what the prediction of the disease later on will be, because we don't see that at the very beginning.
Yeah, and I think it's also very good to focus on this point of mineralization. Indeed, I was also going to mention that those inconsistent results between the studies and indeed what that means. And in terms of what concerns BMD in r-AxSpA, we also have a problem with measurement, because which is the optimal method to measure BMD? Because with syndesmophytes, we can have an artificially increased density of the bone, indeed, and that has limitations, and it's not necessarily at the same vertebral level as where the syndesmophytes are formed. And recently in our group, we have been looking at the assessment of the Hounsfield units, which are measured with low-dose CT. And it seems to be a reliable and a valid method to obtain information on the density of the bone, which eventually, if a low-dose CT keeps surging as an alternative method for the assessment of structural damage progression, can be a way to combine measurement of both. But I think we still need to know more in this field, and I think that the topic or this paper is indeed emphasizing a topic, but perhaps opening more, giving us more questions than giving us answers. So maybe it's a good moment to proceed to the next paper. Hideto, please.
Okay, so over to our second paper titled Implementation of Regulatory Guidance for JAKi inhibitor use in patients with Immune-mediated Inflammatory Diseases, IMID, an international appropriateness study authored by Storitano et al. As a study background, recent guidance from regulatory authorities on JAKi inhibitor treatments has highlighted the importance of considering clinical practicalities prior to their use. High-risk patients are advised to avoid JAKi inhibitor treatments as a first-line therapy. The study gathered an international panel of dermatologists, gastroenterologists, and rheumatologists to determine suitable clinical scenarios for administering JAKi inhibitors in clinical practice and to create recommendations for regulatory guidelines on the use of JAKi inhibitor therapy in high-risk patients. As a methods, the authors conducted a two-round modified research and development University of California, Los Angeles appropriateness methodology study. A panel of 21 dermatologists, gastroenterologists, and rheumatologists used the 9-point Likert scale to rate the appropriateness of administering a JAKi inhibitor for each proposed clinical scenario. Appropriateness scores were categorized as either appropriate greater than 6.5, inappropriate 3.5 or less, or uncertain between them. 2 rounds of online surveys were performed, with a virtual meeting after each to enable discussion and reduce disagreement in scores. And the results? The level of uncertainty and disagreement between panel members reduced following virtual meetings. JAKi inhibitor therapy was deemed to be generally appropriate for the majority of gastroenterology vignettes, depending on the individual patient risk profile. Alternative treatments such as anti-interleukin therapies were recommended over JAKi inhibitors as the first line of intervention in dermatology patients. and JAK inhibitor treatment was only appropriate in low-risk rheumatology patients and only after initial treatment had failed. So in conclusion, JAK inhibitors remain an important therapeutic option for the treatment of IMIDs and can be appropriate for patients with low to moderate risk profiles. Flexibility is recommended for age and smoking history in the absence of other risk factors. Active counseling on modifiable risks is advised, including overweight, mild hyperlipidemia, and hypertension, as well as smoking cessation. Uncertainties remain surrounding some risk factors, for example, cancer history. The Pharmacovigilance Risk Assessment Committee emphasized the importance of assessing JAK inhibitor risk on a case-by-case basis across all specialties. And these recommendations apply to all approved uses of JAK inhibitor therapy in IMID patients. So I think there's some difference between rheumatology and dermatology and gastroenterology, and it may reflect some approved dosing. For example, upadacitinib is approved only for 15 milligrams per day for rheumatology, and sometimes up to 30 milligrams for dermatology, such as atopic dermatitis in Japan, and 45 milligrams per day for inflammatory bowel diseases. So always risk-benefit balance is very important. So Sofia, over to you.
Yes, thank you very much, Hideto. I think this is clearly a hot topic because I think in every podcast, this topic comes in recent papers that are written from a different perspective. This is a very different one because it's not the usual RCT or a post-hoc analysis, but it's a consensus and experts, consensus of experts from different specialties. And I think the attempt was to give some guidance to the practicing specialists based on the EMA warning and recommendations that have been issued. And we hear from practicing physicians that there is some confusion and some lack of clarity exactly what can be done, what cannot be done, what should be done or not. And I think I like in the conclusions that came out of this in where was consensus, where the different specialists felt that some criteria could be a little bit made a little bit more flexible. So when we're talking about age, it's not specifically the 65 only, but we should take age as a continue increasing risk factor with increasing age. But for example, everyone agreed, and I think you will also recognize this from your practice, that it's not that a patient who is 64 has indication for a JAK inhibitor and then patient turns 65 and suddenly has a contraindication. So these are the type of things that should be done with some common sense as well. And a lot of focus has been put on risk factors that can be modifiable and where we can put some efforts in terms of diet, in terms of controlling hypertension, smoking cessation. Those are all possibilities. And at the same time, also knowing that and emphasizing that JAK inhibitors are good and valid therapeutic options. And even if patients have moderate risk, they can be considered, but it's very often weighing the pros and cons, and very often it's dependent on what has the patient already had before. And it's for me also striking what you just mentioned, that rheumatologists seem to be more conservative. That's what came out of that exercise. The question is it really due to us? Are we rheumatologists the problem? So are we too conservative? Or maybe we deal with patients who have more comorbidity, especially when we talk about RA and PSA, which is a very different population than atopic dermatitis and IBD, for example. And it also has to do, a lot came out of the discussions, has to do with what has the patient what has the patient had before as previous treatments, because in a patient who has moderate risk, a JAK inhibitor may be adequate, but if a patient did not yet try another alternative mode of action, perhaps it would be most common to also try it before if a patient already has moderate and certainly high risk. And perhaps we have more therapeutic options available for some of our diseases, where in some areas, especially in dermatology, there are sometimes less options. So perhaps that also influences each of us. Xenofon, what would you think about this consensus exercise and any other take-home messages from your side?
I was rather thinking at the moment, similarly, is it that rheumatologists are more conservative, or is it that we are dealing with, let's say, different types of patients, maybe even other ages of diseases, right? That we see these patients where these indications apply later, and they come in with more comorbidities, hence risk factors. I also agree there must be a cutoff. It's not 64 days, years, and 364 days or so. But and by the way, what we do know is that these numbers are just cutoffs for increased risk as compared to other drugs. It's not that we are killing the patient here and we are saving the patient there. We need to be aware of that. So overall, I think it's interesting to know how this how things are being applied in other disciplines. I do believe it's an interesting information to know what's happening around us, but obviously individualized treatment application applies here as well.
Yeah, I think it's very important what you just emphasized. Indeed, this is not the difference between being harmful or not to a patient, as you just said. So this is the difference of comparing to other drugs. In this case, the existing comparison is with TNF inhibitors and having a slightly higher risk than TNF inhibitors. But so relative risk is higher, but in terms of absolute effect, the magnitude is very low. So still very few patients have this side effects based that were analyzed, namely major cardiovascular events and malignancies. Another comment I would like to make is that I think it may also be the case that oral surveillance has a little bit more impact on us rheumatologists because it was conducted in a population with rheumatoid arthritis. So perhaps we are more susceptible to it, and we are more following the developments in a patient population of ours, so to say, than specialties that do not deal with patients from oral surveillance and who actually don't know whether the risk applies to their populations because this has never been tested. So I think this always keeps back in the back of our mind and of the mind of everyone. And I am afraid that we do not have immediately the responses to this, but the more experience that we get with these drugs in daily clinical practice, the more we also know how to stratify the risk of patients and who are the patients in whom we should be more careful. I think everyone agreed that in patients that are of high cardiovascular risk, then JAK inhibitors are not a first line. And I think that's completely in line with how everyone interprets the precautions issued by EMA. So slowly we understand it better and we know better where to draw the line and where we can be a little bit more flexible. And I think data accumulated in the upcoming years will help us understanding this even better. Any final comments from any of you?
Yeah, that's great. And Sofia, you're one of the authors of this paper, right?
That's true. That's also why I helped giving some insights of our discussions, indeed, because I liked the approach as what we learned through the discussions, indeed. So yes, so I think, thank you very much, Hideto. So I think this will bring us to the ending of this podcast. Thank you for joining us for this podcast brought to you by the Immune-mediated Inflammatory Disease Forum. We really hope you find it useful. And if you did, please don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from, so that you don't miss any future episodes. If you want to read more about what we have discussed today, head over to imidforum.com, where you will find summary slides of both of the papers. See you next time.